Hi there, my name is Kelsey Dumont. I'm a clinical pharmacist, and I'm here today with my colleague Warren Barry, a data specialist. We work for the Opioid Stewardship Program within Saskatchewan Health Authority in Regina, Saskatchewan, on Treaty 4 territory and the homeland of the Métis. Today, we are going to quickly discuss our program's development of a pharmaceutical reporting tool that has allowed us to leverage accessible open source software to develop reports consisting of local data to enhance the efficacy of identifying opioid-related risk factors within our facilities, which can then be utilized to promote appropriate prescribing practices, monitor and evaluate stewardship interventions, to inform health system policy revisions, and to support opioid-related research. As of 2019, Canada was one of the highest consumers of prescription opioids. In Saskatchewan, we consistently have higher opioid toxicity deaths in comparison to other provinces across the country. Where we work, we have 2 acute care centers with a total of approximately 700 inpatient beds to service 500,000 people. However, there are no inpatient addiction medicine teams or acute, chronic, or transitional pain services. Our opioid stewardship clinicians were being consulted on these complex patients beyond our capacity, so we sought to develop an internal clinical decision support system.
The tool is made and run through Python software, and the tool reads in opioid and benzodiazepine order data from the Acute Health System Drug Order Database with an easy-to-use graphical user interface and quickly organizes information in a Microsoft Excel output. The user of the program can view the sorted patients based on their accumulation of risk factors.
Based on predictors strongly associated with fatal and non-fatal overdose found in the literature, we selected the following opioid-related risk factors to capture: administer of naloxone in hospital, or the absence of a naloxone PRN order while the patient had a concurrent opioid order; frequent opioid dosing, which was identified as dosing every 30 minutes up to every 3 hours; IV opioid therapy for greater than 7 days; multiple opioid orders; concurrent orders of benzodiazepines and opioids. We also recognize the highest risk of opioid overdose is in those with concurrent substance use. So we attempted to capture these patients by including those receiving concurrent order for an opioid and those receiving medications for either alcohol withdrawal protocol and or opioid agonist therapy. Additionally, we know that patients are at an increased risk of overdose based on the amount of morphine equivalent dose that they are consuming, but also what they have access to. Therefore, we captured both of these values as well.
We started using the tool in July of 2023, and we screened over 10,000 distinct patient visits, over 65,000 medication orders, and we found over 98% of patients on an opioid had at least one risk factor, with 62% of patients screened with 2 or more risk factors at the same time. And we found the average utilization of available opioids was 16%.
In conclusion, we feel that resource-constrained healthcare systems could leverage accessible data and create a similar tool via open source software to assist in data collection on prescribing patterns, which can then be used to effectively direct both clinical and stewardship interventions.